filter. Okay, so chapter 12 is over drugs that affect urine output. So totally shifting gears here, okay? So diuretic is kind of like an umbrella term, okay? It is a drug class, but there's subclasses that fall under it. So when you're doing your like spiderweb graphic organizer, I would not do diuretics. I would do like each subclass on its own page. Okay. So diuretics work on the kidneys directly, or they might also work by increasing blood flow to the kidneys. What do our kidneys do to the blood? Filter. So yes, cleanse because it gets rid of waste items, but it does that by filtering. Okay. So either way, our diuretics are going to cause an increased urination and water loss from the body because they're either going to work on the kidneys to filter better or faster, or they're going to work on the blood to increase the flow of the blood to the kidneys for more filtration. Okay. A lot of people call diuretics water pills because they make the body lose water. How do they lose it? Yep, urination. Okay, they pee it out. So we use these for different reasons, like high blood pressure, heart failure, kidney disease, liver disease. Urine is made from the blood. The blood travels to the kidneys where there's millions of small tubes called nephrons. The nephrons are the filtering part. Water and small particles like sugar, salt, potassium, and chloride go into the nephrons, and the blood cells, proteins, and large particles go back into the blood. The nephrons take out the waste products, and then the renal tubules take out most of the water and helpful particles and leave the waste, but leave waste products in the urine. I want waste in the urine because it's waste. It's going to leave the body. The clean water and helpful particles are reabsorbed back into the blood, and the waste products and excess sodium and potassium stay in the urine along with enough water to allow them to be excreted out of the body. The urine collects in the bladder until it's ready to be eliminated through the process of urination. Since diuretics increase urination and water loss, it puts the patient at a greater risk for dehydration. Signs and symptoms of dehydration include increased heart rate, low blood pressure, thirst, sunken eyes, dry mouth, skin tenting. What do I mean by skin tenting? Yep, when you grab a piece of skin and pull it up and it just stays up instead of like going back to normal. Constipation and decreased urine output with concentrated urine. Those are all signs and symptoms of dehydration. So we use diuretics to treat the conditions listed here, and I said them, which all involve the body retaining too much water, too much sodium, or too much potassium. So if the problem is too much water, too much sodium, or too much potassium, we're going to give a diuretic. So some things to think about. Schedule your diuretic therapy in the morning. It is not nice to have your patients up peeing all night. What do we call that when they're peeing all throughout the night? Nocturia. before you give these, you want to check electrolyte levels because some of them are going to excrete sodium and potassium, right? So I want to know what those levels are, because if my problem is not related to sodium or potassium, I need to be careful. Check a baseline vital signs because they decrease blood pressure. Check weight. I want to know their baseline weight so I know how much fluid I'm removing. In the other meds that we've talked about so far, we say some of this stuff, okay? But in diuretics, if the electrolyte levels are low, we want to hold the medication and talk to the provider because diuretics are going to further deplete electrolytes. If the blood pressure is low, I want to talk to the provider and see if the patient should receive it, because lowering the fluid volume in the body will also lower the blood pressure even further. Check their weight daily. Monitor their fluid status. I have taken care of patients that a diuretic can make them lose 10 pounds in a day. Yes. Just this weekend, I worked at the hospital and I had a patient on a diuretic and he lost 5 liters in 4 hours. That is a lot of fluid. 5 liters. Remember how much a liter is in a matter of 4 hours. I sent him to the ICU because his blood pressure was so low. Okay. Just like hang out how it. I mean, this particular person had urinals by his bedside, but we were emptying them every few minutes, and he had multiple urinals. If we're going to give them a medication to make them urinate frequently, we want to find out if the patient has any problems with blockage in the urinary tract. What's a potential blockage in the urinary tract for men? I mean, yes, but specifically for men. Yes, enlarged prostate or BPH, benign prostatic hypertrophy. This can cause further problems if they're unable to urinate. Along with your kidney stones, again, you are not wrong with kidney stones, but I was looking for BPH. Any blockage will cause many further problems because they're still going to be creating that extra urine, but where's it going if it can't go out? Okay. Yeah, and how long can it go back in? Think of the bladder as like a balloon. Yes. Yes, I have not personally, but I have worked at the hospital when we've had a patient that had a bladder rupture. Okay, not something that anyone needs to deal with, right? Okay, so know before you give them if they have blockage issues. Okay, the body's producing that urine anyways. It's got to go somewhere. If they have blockage issues, they might need a catheter to get around the blockage to facilitate that emptying of the bladder. Okay. And please make sure your patient has a urinal or a bedside commode and make sure they have their call light. Okay. When these people have to go, they have to go, like right now. These patients are going to be going very frequently and in very large amounts. So we want them to be able to do this without causing them more trouble. Okay. Like by not being able to get to the bathroom. I don't want this person to end up peeing the bed because there's not a way for them to get up and go to the bathroom. And I know a lot of you guys are not going to be working in the hospital setting yet. Some of you want to be nurses, so you will be there eventually. So remember this. But this is stuff to teach your patients because a lot of these meds are given at home. They take them at home. Okay. If it's scheduled to give twice a day, give it like with breakfast and then like maybe 2 p.m. Don't let them take this with dinner. They will be up peeing all night long and they will hate it. And then they'll stop taking the meds, right? And then after we give, we want to monitor vitals, monitor for orthostatic hypotension, monitor intake and output, electrolytes, and daily weights. If we're giving this in the hospital setting, they're going to probably be in higher doses. So those daily weights are very important. If they're taking these independently at home, they may be able to just do a weekly weight, but it's still important for them to monitor. And we teach them that if they have a weight gain of 2 pounds or more in a day, they need to report that to the physician. So again, teach them to take them as prescribed. Early morning is best. But if it is twice a day, take it early morning and then like afternoonish. Don't double it up. I do have some people that don't want to take it later in the day, so they'll take the double dose in the morning. We want it to still be effective throughout the day. Okay. Early morning is good. Afternoon is good. Don't take it at night. And since this is lowering the blood pressure, they should know how to check their blood pressure. I don't expect them to get a manual blood pressure cuff and all of that, right? But they should have some sort of monitor, whether it's electronic, they can put it on their wrist or their arm and check it. They should be monitoring their blood pressure. Teach them what orthostatic hypotension feels like. What does it feel like? Do you even know what I'm talking about? We've talked about it before. So if they change positions quickly and their blood pressure drops. So what that feels like to a patient is they go from laying to sitting and they get really dizzy. What do? I want them to sit there for quite some time before they are not dizzy anymore, before they get up. Okay. Teach them that stuff. Daily weight, potentially weekly weight. It just depends on the severity of your patient's illness. And this is important. I want them to drink a normal amount of fluid. They are not going to like having to pee so much. I guarantee it. Even if they take these first thing in the morning, most of the patients describe that they need to be within a couple feet of a bathroom at all times, okay, to prevent having an accident. That's not going to be fun for someone's everyday life, and I get it. So to prevent themselves from having to do that, they're going to stop drinking as much fluid, and we don't want that. They still need to drink a normal amount of fluid. So the different types of diuretics, because those are diuretics in general. Now we're going to go into each separate type. Okay. The first is natriuretic diuretics. Natriuretic diuretics slow down or turn off the sodium pumps in the nephrons. So they make a person excrete more sodium. Types of natriuretic peptides that is an automatic thing. Types of natriuretic diuretics are thiazide diuretics, loop diuretics, and potassium sparing diuretics. So again, this is an umbrella with those three classes under it. There's also osmotic diuretics. These increase blood flow to the kidneys. We use these in critical care for someone that has an increase in fluid on the brain. That's very specific, okay? And probably not something you're going to see again until you become an ICU nurse. And then carbonic anhydrase and hydrase inhibitors are for the buildup of fluid pressure in the eyes from glaucoma. We'll talk about that more in chapter 27. So thiazide diuretics, your first spiderweb graphic organizer page, okay? Thiazide diuretics include chlorothiazide, hydrochlorothiazide, and metolazone. These work by slowing down or turning off the salt pumps in the nephron tubes. Yep. Thiazide diuretics cause more sodium, potassium, and water to stay in the urine and leave the body through urination. The intended responses are increased urine output, lower blood pressure, and less concentrated urine. Since thiazide diuretics cause more sodium and potassium to be excreted in the urine, side effects include fluid and electrolyte imbalances. This is less likely with lower doses, but we still want to monitor. Other side effects are dizziness and hypotension, and adverse effects are passing out or falling, muscle weakness, and blurred vision. Metolazone can cause impaired glucose tolerance, glucosuria, which just means that we're excreting glucose in the urine, and hyperglycemia if your patient is diabetic. So before we give them, I want to know not just potassium, even though the slide says potassium, but I want to know electrolytes, sodium and potassium specifically, okay? I want to know if they've ever had an allergic response to these meds. I want to monitor electrolyte levels during treatment and after, and teach your patients signs of hypokalemia. What is hypokalemia? Oh my God. Slow. What's the chemical symbol? K? Potassium. Low potassium. Okay. Sometimes if people are on these and have potassium issues, we're going to give them a potassium supplement because these will waste potassium. They'll excrete potassium in the urine. So something that you should tab to be able to come back to a lot is hypokalemia signs. First of all, when I worry about potassium, what organ of the body am I most concerned with? My favorite organ, the heart. If I have potassium imbalances, I worry about the heart. Commit that to your memory. Yes.
You know what page the hypokalemia?
Oh, let's see. Yes, 212 in the common side effects down towards the bottom of that section. Okay, signs and symptoms of hypokalemia: dry mouth, increased thirst, irregular heartbeat, mood changes, muscle cramps, nausea and vomiting, tiredness or weakness, and weak pulses. Most concerning, the one that will hurt you the worst, is heart problems, like rhythm. So for our kiddos, dosing is based on weight. Side effects are the same as adults, okay? Ask women in childbearing years if they are pregnant, plan to become pregnant, or are breastfeeding, because we should not give these during pregnancy or breastfeeding. Thiazide diuretics should be avoided during pregnancy because they can cause side effects in the newborn, including jaundice and hypokalemia. I don't want that, okay? They pass into the breast milk. Thiazide diuretics should be used with caution when a little one has jaundice because the drugs will worsen the condition. In older adults, dizziness, lightheadedness, and hypokalemia are more likely because they are more sensitive to the effects of these drugs. Okay, next drug class, loop diuretics. Loop diuretics like furosemide, bumetanide, torsemide. Do you see how they all end? IDE. That's a really good indicator if you're not memorizing the drugs very well. If it ends in IDE, it's probably a loop diuretic. That goes in the box that says suffix because some drug classes have the same ending. This might be the first one we've come across this semester. Oh, Sillins, yes. So loop diuretics work by slowing down or turning off the sodium pumps in the nephrons in a different place than the thiazide diuretics. These are more intense than the thiazide diuretics. So since they're more intense than thiazide diuretics, they're going to promote more sodium, potassium, and water excretion. Another difference between loop and thiazide is that loop diuretics cause patients to also lose calcium. These are the most powerful diuretics. The intended response: increase urine output, less concentrated urine, lower the blood pressure. Because they're more powerful, the side effects can be more severe. Okay, orthostatic hypotension, decreased sodium and potassium in the blood, and specifically with furosemide, sun sensitivity. Adverse effects: fainting and falling when they're changing positions, muscle weakness, irregular heart rhythms, ototoxicity, and hyperglycemia. Why is ototoxicity on an adverse effect? Ears, yes, ototoxicity is the ears. So ototoxicity, it could potentially become irreversible. That's why it's on the adverse effects. It usually is reversible if the drug is discontinued, but it gets worse if you take other ototoxic drugs. Okay. I also want you to know signs and symptoms of low sodium. Okay, so tab this. Signs and symptoms of low sodium are confusion, convulsions, decreased mental activity, irritability, muscle cramps, and unusual fatigue or weakness. Yes. Directly under where it talks about decreased potassium levels on 212. So our potassium issues are usually going to be related to something heart-wise. Sodium issues are usually going to be related to neuromuscular. Okay, neuromuscular. So the conversation between the nervous and the muscular systems. So before we give them, I would really like to know what their labs are, right? Sodium and potassium. I know that the slides keep saying potassium, but both sodium and potassium. I also want to know if they're on other ototoxic drugs because I don't want ototoxicity to become permanent. I'm going to monitor their sodium and potassium. I might need to give potassium supplements. I'm going to monitor for hearing loss. I'm going to monitor their intake and output. I want to know how much they're drinking versus how much they're losing. When I'm giving a diuretic, because usually in the general world of healthcare, I want intake to equal output. That's beautiful. If I give a diuretic, I want output to greatly exceed my intake because my whole goal is to get fluid off. Okay. Teach them to limit their alcohol and sun exposure. With potassium supplements, also teach them about foods that are high in potassium. I'll let you look those up. It's not just bananas. Okay. Diabetic patients should also check their blood sugar levels regularly when they take these. And like thiazide diuretics, with loop diuretics, kids are dosed by weight. They have the same side effects as adults. Loop diuretics should not be given to women who are pregnant or breastfeeding. Animal studies have shown these drugs to cause fetal harm, so we're for sure not going to try it in a human, right? Furosemide passes into breast milk and should not be used when breastfeeding. But really, no loop diuretics are recommended during breastfeeding. And older adults are more sensitive to the effects. They might have more dizziness, lightheadedness. Falls are more likely. They are also at an increased risk of blood clots and hypokalemia. Okay, next drug class, potassium sparing diuretics. These slow the sodium pumps, so the more sodium and water are excreted as urine. But they do not increase the loss of potassium. They spare the potassium in the body. These include spironolactone, triamterene, and amiloride. The intended response here is that increased urine output, less concentrated urine, and lower blood pressure, but a normal potassium level. So if I'm using some of the others that get rid of potassium and I can't keep potassium in the body, I might switch to a potassium sparing diuretic to keep the potassium. Side effects are postural hypotension, hyponatremia. What is hyponatremia?
Decrease.
What is Na? Sodium. Yes. So postural hypotension, hyponatremia or decreased sodium, nausea, vomiting, stomach cramps, and diarrhea. Adverse effects, fainting or falling, hyperkalemia that leads to dysrhythmias. Finally, one of the slides says something about the potassium being related to the heart. That's what we worry most about with potassium imbalances. Some other stuff that could happen, women might develop hirsutism. This is facial hair, okay? They might also develop irregular menstrual cycles and deepening of the voice. Men might have trouble getting or keeping an erection. And both men and women might develop breast enlargement. In men, that's termed gynecomastia. Triamterene could cause photosensitivity.
Isn't that like sensitive to like light or something?
Yes. Yes, sensitivity not to having your picture taken, but to light. So artificial light or sunlight.
If it's sensitivity to having your picture taken, then I already.
You already have it.
I
Okay.
like people taking.
So giving potassium sparing diuretics with potassium supplements, salt substitutes, or ACE inhibitors can increase the risk for developing high to extremely high potassium levels. So if I'm taking a drug to hold my potassium and then I have other drugs that potentially will hold on to potassium, I can have lots and lots of excess potassium, heart problems. Okay. So before we give electrolyte levels, okay, monitor electrolyte levels with diuretics. Okay. Teach our patients and residents to avoid excessive amounts of high potassium foods. So in the other ones where I'm peeing off lots of potassium, I want them to eat potassium high foods. If I'm taking a med where I'm holding on to or retaining potassium, I want them to avoid high potassium foods. Okay. Also, no salt substitutes. Have you guys ever heard of like Mrs. Dash, those salt substitutes?
My dad used that.
All it is potassium. So I don't want them to use those. Okay. So safe use of these drugs is not established or researched in kids, but side effects are expected to be the same as adults. Expected to be. Well, are we going to chance that? No, because we don't know. But since we're not about this, or since we're not sure about safety for kids, we're not going to give them. Okay. And the safe use while pregnant or breastfeeding hasn't been established either. So we're not going to give them to moms who are pregnant or breastfeeding. Okay. They do pass into the breast milk. We know that. There have been problems, or there haven't been problems for the infants, but why chance it if it's not determined yet, right? And in older adults, they're more sensitive to the side and adverse effects. Then we're going to go over to overactive bladder. Okay, so we're still in urinary, but a little bit different here. In people with an overactive bladder, the smooth muscle that surrounds the bladder, this is called your detrusor muscle, contracts like spastically. Okay, so it spasms, sometimes without a known cause. So if I'm having a spasm around my bladder, I'm going to have an urgent pressure and an urgent need to urinate. Okay. Overactive bladder interferes with work, because you're standing here working and then all of a sudden you have to go like right now. It interferes with your daily routine intimacy, sexual function. It's embarrassing. It can, diminish your self-esteem, your quality of life. So to fix it, we use urinary antispasmodics. Okay, so if you break that down, anti means no, spasmodic, so no spasming of the bladder, right? They decrease the spasms of the detrusor muscle. Kegel exercises or Kegel exercises involve contracting and relaxing pelvic floor muscles in order to help strengthen and improve the muscle tone and help control urinary incontinence. So that is helpful as well, okay, to teach your patients. But we're going to use the urinary antispasmodics to stop the contractions or the spasms of the bladder. And then hopefully they're doing Kegel exercises to help prevent the incontinence or the leaking, okay? Some examples are oxybutynin, tolterodine, daraphanicin, but usually oxybutynin and tolterodine are what you're going to see. The intended response here is to decrease the urinary frequency, urgency, and incontinence. So these drugs are going to kind of dry everything up along the way. So side effects, dry mouth and dry eyes, headache, dizziness, and constipation. Some other less common side effects would be like nausea, drowsiness, some blurred vision, because if I have dry eyes, I'm probably going to be a little blurry, right? And dyspepsia, that just means heartburn. Adverse effects are chest pain, a fast or irregular heart rate, shortness of breath, swelling or edema, and rapid weight gain. Because remember, I'm stopping the urination. I'm kind of drying everything up. So if I'm holding on to lots of that water instead of urinating it out, that could be a problem. Also, confusion and hallucinations. Some signs of an allergic reaction would be stuff you already know. Hives, difficulty breathing, swelling of the face, lips, and tongue or throat. What do we call that? Angioedema. Yes.
I said facial.
Patients might be at increased risk for heat stroke during exercise or hot weather because these also decrease perspiration. Adverse effects also include possible decreased urination or no urine output and painful or difficult urination. Yes, dysuria. Thank you. So I'm teaching my patients to swallow these capsules whole, take them on an empty stomach with water. That's weird, right? Normally we say they should be taken with food. Take them on an empty stomach with water. If they do miss a dose, they should take it, okay? If it is too close to the next dose, then they can skip it. I don't want them to be overheated or dehydrated because these prevent them from sweating. I also want these people to weigh themselves daily because I want to know if they're retaining too much urine. I want to make sure that they're not gaining weight too fast. I also want to teach them to avoid driving and alcohol with the, avoid alcohol while taking the drug, but avoid driving within a couple hours of taking the drug. Okay. Again, remember blurred vision, dry eyes. Okay. Monitor patients for urinary urgency, frequency, difficulty urinating, or incontinence. Keep track of fluid intake and output. Report weight gains of more than 2 pounds a day. If they do have an upset stomach, they could be taken with food or milk, but typically we want them on an empty stomach. Okay. Let's see. And the side effects of drowsiness could possibly be potentiated with these drugs, especially if they are consumed with alcohol. That's why we want to avoid that alcohol. Okay. Oxybutynin is low risk for pregnancy and lactation. We like low risk, right? Other OAB drugs have a moderate likelihood of increasing the risk for birth defects or fetal damage, so we don't use them. In older adults, they might be more sensitive to the drug's effects, so they might need lower doses. That's it.